Hello, everyone. My name is Krishna Gunturu. I'm an oncologist by profession and founder and director of Survivorship by Desire. It is my pleasure to welcome you all to our third annual Survivorship Symposium. With advances in screening, treatments, and supportive care, more people are living longer with good quality of life. Our goal with the Survivorship program is to empower you to live a full life by providing resources. My motivation behind founding Survivorship program is personal. With losing my father at the age of 15 to lung cancer within 4 months from the diagnosis and facing the aftermath. This motivation alone is not enough to establish this program. It was only possible with the support from our core survivorship members, from rehab, nutrition, psychology, hematology and oncology department, colleagues, and leaderships, Doctors Heskett, Stewart, and Zarwan, along with other departments. I would also like to thank Dr. Tatai, who graciously accepted to carry on this program after I leave Lahey soon. Let me introduce Dr. Tatai here. Lata, do you mind?
Hi, I'm Lata Tatai, and thank you, Dr. Gunturu Krishna. I'm hugely appreciative of all the work you and the survivorship team has put into organizing the symposium, especially appreciative of your efforts in founding the survivorship program and going over and beyond what the Commission on Cancer has required the Cancer Center to provide for its patients. And I know personally that my patients have benefited hugely from the survivorship visits. I'm honored to take on the directorship of the survivorship program, but very sad to see a good friend and a great colleague, Dr. Gunturu, leave us for Hartford. Thank you.
Thank you very much, Dr. Tatai. I know it's very sad to leave, and I know that it's in very good hands. Thank you. And I would like to extend special thanks to Alana for all her efforts and as coordinating this event, which is not easy task, and also with the survivorship team, everything too. And I would also like to thank our BI Beth Israel team, and everyone else who is behind the scenes. And more importantly, this would not have been possible without all of you, survivors and caregivers. Thank you very much. Without further ado, let me introduce our first speaker. And what I'm going to do this evening is going to introduce the speakers just before their presentations. And there is one small change in the agenda today. So at 6:30, pelvic floor therapy will be presented by Alexis English. And at 6:40, Dr. Ganatra will go over the cardio-oncology program, intersection of cancer and the heart. So let me introduce Dr. Thibodeau. Catherine Thibodeau is a licensed psychologist with a specialization in health psychology and behavioral oncology. She has a background working in primary care, women's health, and inpatient medical settings. We welcomed her to Lahey Cancer Center team in March of 2022, and since then, she has been tremendous resource for us, taking this program to the next level. And now we have our support groups, and with Dr. Sheets and rest of the behavioral oncology program, you are doing a lot of good resources and providing information for our patients and caregivers. Dr. Thibodeau.
Hi, everyone, and thank you so much for joining us this evening for our third annual Survivorship Symposium. As Dr. Gunturu mentioned, my name is Catherine Thibodeau. I'm a licensed clinical psychologist and I provide cancer-focused individual and group therapy support here in oncology at Lahey. This evening, I'm going to be providing an overview of the psychosocial support that my team offers for individuals with cancer and their families. Next. So first, I'd like to review how we define psychosocial oncology. The field of psychosocial oncology addresses the various psychological, emotional, behavioral, and social aspects of cancer. It not only focuses on the patients themselves, but also patients' social networks, including their caregivers and loved ones. Common psychosocial concerns for patients with cancer may include strong feelings of anxiety and depression, decreased ability to engage in enjoyable or meaningful activities, trouble making decisions, particularly related to their treatment, not feeling as connected to family and friends, as well as changes in self-esteem and body image. Next. As psychosocial oncology clinicians, we utilize a framework called the biopsychosocial model. As the name implies, it takes into account the various aspects of a person's biological, psychological, and social well-being. This framework helps us gain a comprehensive understanding of our patients. As therapists, we not only address how our patients are thinking and feeling, but we also explore their experiences of various medical stressors and physical symptoms such as pain and other physical side effects of treatment, which are particularly relevant in the cancer patient population. We also address the various social and systemic stressors a patient might be facing, such as challenges with relationships or difficulties navigating the healthcare system. Next. There are many different reasons why a patient might be referred to see a therapist within oncology. Sometimes these have to do with difficulties adjusting to a new diagnosis or treatment. Some of the most common emotional issues that come up for patients when they're first diagnosed include feelings of anxiety and depression. They may also come to therapy to process a sense of loss related to their diagnosis, as they may be grieving the future that they had always imagined for themselves. They may also have difficulties coping with various side effects of treatment or changes in physical appearance that may contribute to issues with things like body image and self-esteem. Patients often struggle with fear of the unknown, which can trigger what we call scanxiety, meaning anxiety before scans and while waiting for results. There are also many reasons why patients might be referred to us after they've completed treatment for their cancer. They may be in a space where they're ready to reflect on their experience of cancer and any related changes in perspectives, values, and goals. They may also start therapy due to difficulties finding what many call their new normal. It can be quite difficult for patients to transition back into their regular activities and hobbies, as well as their job responsibilities. They may find that they're unable to engage in these activities in the same way they previously did before undergoing treatment. In addition, patients may experience increased anxiety and fear of their cancer recurring. Some people find that their anxiety about their health actually increases as the frequency of their medical visits decreases. And therapy can help patients address feelings of anxiety and fear while also learning various strategies to cope. Next. Okay, so when you are referred to our psychosocial oncology team, you'll meet with one of our 4 clinicians. We have 2 psychologists and 2 clinical social workers. Dr. Jennifer Sheets and I are both licensed clinical psychologists with specializations in clinical health psychology. We provide individual and group therapy for patients within our oncology department. Mark Leone and Ariel Cussin are both licensed oncology social workers who provide individual and group therapy support to our patients as well. And as social workers, Mark and Ariel also provide additional support within our clinic, including connecting patients with various resources, such as transportation assistance. Next. The individual therapy that we provide is focused on cancer-related stressors. It is available to patients as well as caregivers. We conduct one intake assessment where we gather information about a patient's experience with cancer. We learn about their engagement in treatment and any recent challenges they've faced with their physical and mental health. And we also explore the patient's goals for therapy. This assessment helps us determine the direction of therapy treatment, which could be either short-term, which we would define as 1 to 3 visits, or more long-term throughout the patient's cancer treatment and beyond. Patients are given the option to attend therapy virtually, as well as in person in our oncology clinic. In terms of frequency, some patients prefer to check in with their therapist on an as-needed basis, for example, before or after scans, whereas other patients prefer to have ongoing scheduled visits, which could range from anywhere between bi-weekly to every 4 to 6 weeks. Next. The goals of therapy are developed collaboratively between patients and their clinician. Some common goals of cancer-focused therapy include developing coping skills to better manage cancer-related stress, enhancing self-care activities to support mood, improving relationships and the quality of a patient's social support network, as well as improving communication and engagement with medical providers. Patients often utilize their therapy visits as a way to reflect and process various feelings about their disease and treatment. Sometimes they'll process things that they don't feel quite ready to process with their family and friends. Next. And over the past several months, our psychosocial oncology team has launched several therapy groups. These groups are offered on a monthly basis, and as of now, they're all meeting via Zoom. We offer a monthly group for patients who have been diagnosed with breast cancer, regardless of their specific disease type, stage, and treatment plan. Our clinical social worker, Mark Leone, facilitates a monthly men's group. This group is a place for men to come together to discuss the impact that cancer has had on their lives and share their experiences with others. Another group that we recently launched is our monthly therapy group for young adults. This group is for patients between the ages of 18 and 40 years old who have been diagnosed with cancer, regardless of the type, stage, or treatment. Patients in this group process and share their unique challenges of having cancer as a young adult and learn various coping strategies to manage their various health-related stressors. We also offer a monthly therapy group specifically for patients with metastatic disease who are currently receiving treatment. And one of our most popular groups is actually our post-treatment therapy group led by Dr. Jennifer Sheets. This group is specifically for individuals who have completed active treatment for any type of cancer. And in the group, they explore themes pertaining to physical and emotional wellness, body image and identity, spirituality and mindfulness, work-life balance, among many others. We're also very excited to announce the launch of 2 additional therapy groups within oncology. So starting in October, we will be offering a monthly women's group, which will be a space for women with any type of cancer to come together to discuss the impact that cancer has had on their lives. And then we'll also be offering a group for patients who are newly diagnosed with cancer, who are expecting to begin or have recently initiated their treatment. Topics for the newly diagnosed group will focus on navigating the unknowns and uncertainties associated with treatment, as well as exploring the impact of individuals' diagnosis in their various aspects of life. Patients will be able to share their experience and also build community as they work to identify ways to cope with the emotional distress associated with a new cancer diagnosis. Next. So if you're interested in joining a monthly therapy group or would like to start individual cancer-focused therapy, you can request a referral from your oncology provider. And I just want to thank everybody again for joining us this evening. And to learn more about the programming that the psychosocial oncology team here at Lahey offers, we encourage you to reach out to us for some additional information. And I've provided the number right there to call at 781-744-8400. Thank you again.
Thank you very much, Dr. Thibodeau. That was a very nice summary of what are the resources that are available in our cancer center, and also how to reach. You can talk with your primary oncologist to make a referral to either Dr. Thibodeau or Dr. Sheets or any of the rest of the behavioral oncology team. And thank you very much for all your hard work to the behavioral oncology team. Thank you. So our next speaker is Dr. Candia Oliver. She's a clinical psychologist specializing in health psychology and behavioral medicine. Originally from Arizona, she ventured away from home to receive her PhD in clinical psychology from the Ohio State University and completed her clinical internship in behavioral medicine at the Boston VA Medical Center. She then completed a clinical postdoc in integrated primary care and behavioral medicine at the Edith Nurse Rogers VA Medical Center in Bedford, Massachusetts. She currently works as a clinical psychologist at Lahey in several outpatient medical clinics with an emphasis on helping individuals manage anxiety, health behaviors, difficulty coping with chronic medical conditions, and insomnia. So I'd like to welcome Dr. Oliver and love to learn more about sleeping behaviors, which all of us can use.
Yeah, thanks very much for having me. So we'll talk a little bit today just about some really basic things to think about when engaging in healthy sleep patterns, as well as what situations might require more intervention. All right, next slide. So a couple of things first, I always go over just like what's normal for sleep, so we actually know kind of what's realistic and what to expect. Typically we give the range about 7 to 8 hours is what we're hoping for. 7 to 9 is kind of the wide end of that range. And as long as we're hitting somewhere within that, that's the general recommended amount of sleep for adults. And it's also pretty typical to actually wake up during the night. And it'd be great if you didn't, but if you wake once or twice, say for like a quick bathroom trip or to like change positions at night, that's really typical. What's atypical is if you're frequently waking, say 3, 4, 5 times a night, or if those awakenings are lasting a really long period of time. Those usually are things that we look into to figure out what else might be going on. And there's a couple other reasons we'll talk about later for why that might happen, including issues with pain, but we'll kind of come back to that. And then a few things just to know that as we get older, our sleep does tend to change a little bit, but not in some of the ways that we often think. For one, the depth of our sleep does get a little bit worse overall in terms of we have a little bit less time spent in that super deep sleep. So you might notice your sleep feels a little bit lighter as you age. This actually starts as early as your 30s and then just kind of continues onward. The timing of our sleep can tend to shift over time. So we might want to find ourselves wanting to go to bed a little bit earlier, waking up a little bit earlier, having more difficulty trying to sleep in a lot later. And again, there might be a slight shift in those number of awakenings. If you were someone who never woke up during the night, you might find that now you're starting to wake up once during the night to use the bathroom. Again, that's fairly typical. One of the biggest myths, though, is that you need less sleep as you age. That is not true. That 7 to 9 hour range stays basically until from like you hit age 18 until death. So anyone tells you they only need 5 hours of sleep, that's not true. They still need it. All right, next. So insomnia itself, when we were talking about clinical insomnia, this is having difficulty with either sleep quality or quantity that typically is going to happen at least a couple nights a week, so about 3 nights or more, and is persistent for over 3 months or longer. It's really common for people to experience brief periods of acute insomnia throughout their life where it's short lasting, but clinical insomnia is where that just continues to really persist. That can be difficulty falling asleep at the beginning of the night, difficulty maintaining sleep throughout the night, or waking too early and just not being able to get back to sleep again. Oftentimes it's some combination of those things. And again, when we're thinking of it from a clinical perspective, it's also disruptive enough that it's causing impairment in functioning, excessive fatigue during the day. Again, just maybe making us really irritable where it's harder for us to function socially. So next. And in terms of the impact of poor sleep, so there's definitely a few things that we really think about. Obviously, getting poor sleep is not super great for your physical health or obviously for our psychological well-being. And the difficult part of that is our physical health and our mental health also can be contributing factors to that insomnia. So it can feel like a vicious circle sometimes. When we're not getting poor sleep, that adds to more burnout, which tends to make us want more sleep. And again, that vicious cycle continues. And it can affect our general productivity and cognitive functioning throughout the day. Tired brains don't like to work very effectively sometimes. Next slide. So let's talk about what we do about it. So one of the first things that we go over when it comes to healthy sleep behaviors is actually really focusing on this concept called stimulus control. It's a really fancy way for saying your bed is for sleep. And for this, we go back to an old psych concept. If any of you ever took Psych 100 at some point in school, you've heard about Pavlov's dog and classical conditioning. The simple version of this, and the one I use for all my patients, is thinking about kind of a really common example is where we take a neutral item and we learn to have an automatic association or reaction to it. The most common one we all experience is actually the movie theaters. So when you go to the movies, think about the first thing you want to get, and it's usually popcorn, right? And it's not only that I want popcorn, but I also feel hungry for popcorn. There's that initial kind of urge of hunger, that natural reaction. Now, you might have just come from a really large dinner and you are super stuffed, you don't need more food, and yet get into that movie theater, that's the first thing that you start to notice. And it's because the marketers in movies understand how psychology works, and they've done an incredibly effective job at pairing movie theaters and eating popcorn together over and over and over again, that now just going there makes us hungry, right? So when we take that same idea and we apply it to the bedroom, we want our beds to be super strongly associated with this natural response of sleepiness. I want my bed to cue me to feel sleepy, like that movie theater cues me to feel hungry, right? And what often happens in insomnia is over time, my bed is just the source of stress. It's a thing I don't like. It's the place I'm going to toss and turn all night long. It becomes a place that I associate with alertness, right? And so one of the best things we can do to affect that is to not actually use our bed unless we're sleeping. So next slide. So what that looks like is basically our bed is only for sleep. Sex is your one exception. That means that I am really intentional about being in bed when I'm sleeping, even if it's taking a nap in the afternoon, which we'll talk about later. That means I'm also getting out of bed if I'm not sleeping. So from a practical purpose, that means at night, beginning of the night, I get into bed, I get ready to go to sleep. And if it's been about 15 to 20 minutes, and this is not, I don't have to check the clock to make sure it's precise. The idea is give it a good try at the beginning of the night. If it's just not happening, that's fine. I'm actually going to get out of bed. Perfect world, I'm going to a completely different room. Next best option, go sit somewhere else in your room that is not your bed. Last, but still decent option is get into what we think of like as a sleep position versus a wake position. Sleep position, I'm on the side of the bed I normally sleep on, head on the pillow, under the covers. Wake position would be I'm on top of the covers, sitting up. I can sit on a different end of the bed or side of the bed. I'm going to do that. Again, trying to make as much of a distinction as I can between how I use my bed for sleep and how I use my bed when I'm awake. So once I've gotten out of bed, after about 15 to 20 minutes of not being able to sleep, I don't want to just go sit on the couch and like twiddle my thumbs thinking about the fact that I'm not sleeping and just getting frustrated, because that's not going to help me either. So instead, what I want to do is I want to engage in a relatively boring or relaxing activity until I feel sleepy. So first, we always tell people nothing with screens, and then I immediately give you some exceptions to that. So your exceptions are audiobooks are fantastic. We love audiobooks. You can use those because, again, I don't have to have any lights on. I can just go press play and listen to a book. Podcasts are fine. For both of these options, again, you're finding either a book or a podcast that doesn't get you super excited. It doesn't make you anxious. You're not super invested in what's going to happen next in the story. It's something that's fairly relaxing, if anything, maybe a little bit boring, or again, comforting, maybe a book you've already heard or read many times before. Kindles are generally okay. We're going to try to avoid reading things like on our screen or like on a laptop or computer. But your other best option would be read an actual book. Again, something that feels a little dull, a little boring, or basic kind of calming. I'm going to do that with a low reading light. I don't want to turn all the lights on in my room. Other activities that you can do that work really effectively, coloring books are actually really good. They give you something else to focus on without really having a whole lot to focus on. So, and they're pretty relaxing. Crossword puzzles, Sudoku puzzles, anything like that. I can go and get the cheap books you get at like CVS or the grocery store. Just again, kind of going through those. If you knit, crochet, anything along those lines. I'm basically thinking about the activity I'm doing is something that is helping to kind of calm my brain, give me a nice, healthy distraction at night, and it's just buying me time to feel sleepy again. Once I think I'm noticing that sleepy feeling, kind of that heaviness in my head, that's when I'm going to go back into bed and try again. Now, there's some nights I might find I have to do this a couple times, but if I'm really, really strict about this, what you tend to see happen pretty quickly is I'm no longer having to get out of bed. Again, because my brain is much better at making that association between my bed and sleepiness, and is actually helping me to feel sleepy once I get into bed. All right, next slide. So again, I mentioned that earlier. So one of the things we think about is like sleep versus wake position. We talk about this a lot if I am working with someone who has, say, a medical reason why getting out of bed in the middle of the night might be more challenging, if they've got mobility issues, or again, are just in a really small space. Then in that case, again, kind of having that sleep position versus wake position is helpful. This is also true for people who often use their bed to lie down because of issues with fatigue or pain, if like that's the one comfortable place that they can go during the day. Again, my goal is to try and think about how can I create a space here that is going to feel like this is what I'm using, how I'm using my bed, when I'm using it to rest during the day, if I just need to rest my body, kind of let myself lie down. Versus when I'm using it at night to sleep, or if I'm using it to take a nap during the day to sleep. If pain is a factor that wakes you up during the night, this is another one we want to think about. So when it comes to pain management, if pain, say, is a factor preventing you from falling asleep at the beginning of the night, or again, wakes us up during the night, I generally want to focus on pain management strategies first, and then switch to that relaxing or boring task. So in this case, if it's, let's say it's time for me to take a medication again, then I'm going to take that first. So it's take time to get absorbed and kind of have an effect in your body. So I want to do that first thing first. If I'm using heat or ice, or I use a TENS unit or massage, like light stretching, any of those things, I generally want to start with that piece, kind of get that set up, or start engaging in those behaviors before, say, switching to my audiobook or putting my music on, things like that. And this is true if there are kind of other medical symptoms that are waking me up during the night. I generally want to address things first. I don't want to try and ignore that and focus on the relaxing activity, kind of hoping that'll go away. If there's things that I can do to better manage it. If it's nausea that's waking me up, again, what generally helps me with managing the nausea, and then switch to the distracting tasks. Okay. Next slide. So outside of our sleep window, we're also thinking about kind of the activities we're doing right before we go to sleep, and then kind of how we're managing sleep during the day. So the last 30 to 60 minutes before we go to bed is what we call your buffer zone, cool down period, wind down time. There's like 10 different names for it. Basically, it just means that's the time that I want to take to do more relaxing activities. It's very much how we treat young children, right? Young children have a nice bedtime routine. We do things like lower the lights, kind of dim the lights, lower the volume, reduce the intensity of activities that we're engaging in, with the hope that by time bedtime hits, they're actually going to feel sleepy and like ready to go to bed. No sane caregiver is like asking a little kid right before bed what they're scared about the next day. If they are really excited about some trip coming up, like that kid's just not going to sleep, right? And yet as adults, we do things like watch the evening news right before we get into bed, or we go and like look through our emails or plan out like some meeting for the next day, and then we get into bed and are surprised when we can't turn our brains off and I can't get my body to relax. So I really want to be mindful of the types of activities that I'm doing right at the end of the night, so that it's really helping to promote this idea of feeling more relaxed, feeling pretty calm, less stressed. And that way I'm also better at noticing when my body is giving me that cue to feel sleepy. With napping, similar idea. I want to try and actually limit naps to the extent that I can. And this is particularly true if I'm having a lot of difficulty with sleep at night. For the most part, if I don't need to take a nap, don't take a nap. But if you do, early afternoon is generally the best time to do that. If you're on a pretty typical sleep schedule, early afternoon is when your body is actually most prepared to take a nap. It's going to be the easiest time to do it, say like 1 to 3 o'clock range. I want to try and keep the nap. There's still good benefit from even keeping it around 30 minutes. 90 minutes actually gets you through a full sleep cycle. So kind of think those two tend to be the 2 ranges that work best for us. Some people find that 60 minutes works great. Again, it's kind of figuring it out. But the idea is I don't want to do a 3-hour, 4-hour, 5-hour nap, because that's going to actually make it harder for me to sleep the next night in many cases, right? Again, in bed when possible, because we use our bed for sleep. Next slide. And then I really want to think about my sleep schedule. So we want to make sure that we're trying to wake up at the same time every day, and preferably going to bed around the same time every night. Having a lot of consistency helps with regulating our sleep. There's this concept called social jet lag, which is where I go to bed later and sleep in later on, say, Friday and Saturday night. And then usually those are the people that have the most difficulty with sleep come Sunday night and Monday, because we've now shifted our schedule a full several hours for 2 nights. It's a lot easier to push our schedule backwards. But now when I suddenly have to go to bed early and I only woke up 12 hours ago, I'm running into issues, right? So trying to keep more consistency within our sleep schedule could be really helpful. Also thinking about how big or small our sleep window is. Sometimes people come to me because they're reporting insomnia, but they literally only gave themselves 5 hours for sleep. That's not insomnia, that's just not giving yourself an appropriate sleep window. Oftentimes in insomnia, people might be giving themselves way too wide of a window. They're trying to sleep between 10 p.m. and 8, 9 a.m. the next day. That's too wide. And what they tend to find is that they're having difficulty falling asleep, or they're having these big chunks where they're awake during the night because their sleep window is not tight enough. We're not getting too into this today, but the idea is my sleep drive is this similar to hunger. If I go and I eat a bunch of snacks right before dinner, I'm not going to be as hungry. It's going to be harder to eat a full meal. Because I didn't eat a full meal, I'll also get hungry again pretty quickly. Same idea for sleep. I actually want to get my sleep in one big chunk. And so I actually want to keep it a little bit tighter. So if I'm someone who needs like say 7.5 hours of sleep, I want my sleep window to be about 8 hours in a perfect world. Okay. So tendency when I can't sleep is to widen the sleep window. We actually want to avoid that. It kind of works against you. All right, next slide. So another piece that we talk about with healthy sleep behavior is using relaxation exercises. We're just kind of briefly mention these, that they exist. These are out there. So diaphragmatic breathing is just another fancy name for deep breathing exercises, progressive muscle relaxation, guided imagery. These are all types of relaxation practices that you can do that help your body to physically relax. And they're things that we can use both before we go to bed or should I wake up during the night and have trouble getting back to sleep. At the end of this, I'll show you an app that you can use that actually has free recordings on there of all of these. But also you can find them on Spotify, Apple Music, YouTube, all of that. Certain mindfulness and meditation exercises can be great. Just don't do one that's trying to make you more alert. So just keep that piece in mind. But But the general idea is anything that helps us to bring our arousal level down in the evening is going to help us promote better sleep quality. So I don't want to be doing super intense exercise right up until my bedtime. Exercise wakes me up more. So I need time for my body to cool down before going to sleep. Next slide. Trying to watch time. So another one is thinking about how our thoughts impact our sleep. Really briefly, this is something that if you're finding you have a lot of worries that are like significantly impacting your ability to get to sleep or stay asleep, that would be a great one to go and work with a therapist to help figure out how to manage more effectively. But some of the biggest things that we talk about in here are trying to manage some of these assumptions about sleep and what's going to happen if you don't sleep. For example, I'm not going to be able to function tomorrow if I don't get enough sleep today. Most common example I give people is usually I've met people who've had insomnia for years or decades. And at that point, we do a quick review and we say, think of all the days you've had in your life that you haven't had great sleep. And how many of those days, like the following day, were realistically fine, neutral, not great, not terrible, manageable. And the reality is, like, most of us actually do a fairly good job managing on not great sleep, especially when we've had to deal with it for a long time. So a lot of times our tired brain at night is telling us this is going to be absolutely horrible if you don't get enough sleep, but frequently that doesn't match up with reality. So we spend a lot of time in therapy working with patients on how to kind of reframe these thoughts to be a bit more realistic and trying to take a little bit of that pressure off of ourselves to get great sleep. Because ironically enough, less pressure we put on ourselves to sleep, the better our sleep tends to be. Next slide. Lastly, too, if I've got a lot of thoughts that tend to pop up at night, write them down. Writing them down on a piece of paper, giving yourself some time to actually problem solve when possible, but even just writing it down on a piece of paper acts as external storage for your brain and can make it less likely that you keep repeating these thoughts to yourself at night as you're trying to sleep. We use the example of don't think of a white bear, because if I ask you all right now to not think of a white bear, I guarantee you just thought of a polar bear, right? Telling myself just don't think about it doesn't work. Writing it down becomes at least a quicker, more effective strategy to get that thought out of your head, at least a little bit. All right, next slide. So last quick things. So this is what we kind of traditionally think of as sleep hygiene. These things in and of themselves are not gonna fix it if you've got chronic insomnia, but they're still helpful from a sleep quality perspective. Basically, I want a dark, cool, quiet room. I want to try not to have a massive meal right before I go to bed. My body needs time to process and digest that. I don't want to watch the clock at night. It honestly doesn't make a difference if you woke up at 2 or 4 a.m. Watching the clock, though, can accidentally train your brain to get up at that time. Also, we do that fun mental math, and very rarely are we comforted thinking about, oh, I only have 3 more hours before I have to get up in the morning. Usually that makes us more anxious. It doesn't matter. Don't watch the clock. We use our other strategies about getting out of bed instead, regardless of what time it is. Again, mention timing of exercise, thinking about the timing of my caffeine use. If I'm really sensitive to caffeine, cutting that off even earlier in the day, but it's usually about 6 to 8 hours before your bedtime. And then again, limiting like alcohol, other substance use before I go to bed. Alcohol disrupts my sleep quality. Nicotine as a stimulant wakes me up more. All right, next slide. So this is just your kind of quick summary. So again, I'm thinking consistent wake time. I want to go to bed when I feel sleepy. I'm going to try and go around the same time, but if I'm completely wide awake, don't try and force it. Sleep isn't something I can force. Really focusing on using my bed for sleep only. Get out of bed if I'm not sleeping. Doing a nice cool down routine before I go to bed. And again, seeking professional support if I find that I really am having continued difficulty managing my sleep, because there are treatments out there that are effective for managing this. All right, last slide. So this is just a workbook that goes over a type of treatment called cognitive behavioral therapy for insomnia. It's kind of best if you do it with a provider, but if that's not an option for you, it's something that is also kind of designed that you can go through on your own. And then CBTI Coach is a free app that was developed by the VA and Stanford specifically for patients with insomnia. This is the one that also has under the tools section, it goes to a place called Quiet Your Mind, and it has a bunch of free recordings of relaxation exercises. It's got some audiobooks on there and some mindfulness practices. And that's it. All right, thanks guys.
Thank you very much, Dr. Oliver. So I'm definitely going to get a notepad right next to my bed to write down at night. So, and thank you for all the tips, and hopefully all of you can get a better night's sleep soon. Thank you. So our next speaker is Ronald Ponchak. Ron is a physical therapist and executive director of clinical services for rehabilitation, emergency, anesthesia, and pain. He has been with Lahey for over 8 years and previously worked in Connecticut and owned his own physical therapy practice in New York City. He has been a physical therapist for over 35 years and is a graduate from Ithaca College for physical therapy and Quinnipiac University for Masters of Business Administration. Take away, Ron.
Thank you, Krishna, and thanks for having me here again. I always enjoy this this event. Hopefully, y'all can hear me. A little scratchy throat today. As Krishna said, I'm a physical therapist, and I'm going to cover a little bit in the next 10 or 15 minutes on function and fatigue. And fatigue is one of the things that a lot of our cancer and survivor patients face. Is a very common ailment. Next slide, please. So fatigue can take many shapes and sizes. It can feel like physical, emotional, or mental exhaustion. One of the keys to think of is it's not quite the same as feeling tired, or as Kendia just talked a lot about, it's not getting enough sleep. This is different than just a lack of sleep. It can affect your activities of daily living. It does not match the level of activity. People can feel fatigue even when they're not very active. It does not improve with rest or sleep. It can be caused by the cancer itself, cancer treatments, or other factors. It can differ from one day to the next. It can be highly variable. Next slide. Some of the causes of fatigue and factors that can influence it. It can be a side effect from chemotherapy, radiation, immunotherapy, other medications. It can be related to things like anemia, where decrease in your red blood cell counts can provide less oxygen for your body's needs. It can be dealing with pain, deconditioning, hormonal imbalances, emotional distress such as anxiety and depression. It can be due to partly poor sleep and sleep hygiene, as Kendia went over. It can be from nutritional imbalances or nutritional deficits. And it can have a lot of other medical issues, things like cardiac and pulmonary diseases, infections, etc. Next slide. I appreciate Kendia's use of having Snoopy involved. I'm a big Peanuts and Snoopy fan myself. I think everybody is. How can fatigue affect us in our quality of life? And it's pretty widespread. It can affect family and social relationships. It can affect one's ability to cope with treatment. It can influence mood, emotions, mental focus, daily activities, the ability to care for oneself. Obviously, it can affect things like job performance, hobbies, recreation. It can erode somebody's hope for the future. And it can certainly impact, the level of physical activity. Next slide. I mentioned physical activity because that's actually one of the key components to working with fatigue and working through it and improving it. A lot of studies have been out there lately in the last several years. There's two I'll mention here. Exercise has a powerful effect on cancer-related fatigue, and fatigue levels were 40 to 50% lower in exercising participants. There's high level evidence supporting exercise as an intervention for fatigue. And it might sound counterintuitive, but more and more studies are showing this. The American College of Sports Medicine recommends, that an exercise routine for people to be 3 times a week for 30 minutes of moderate aerobic exercise. Think of your cardiac type exercises, plus up to 2 times a week for resistance training with major muscle groups and moderate intensity. Next slide. What's important to pay attention to as you begin an exercise program or undertake an exercise program is pacing and energy conservation. So we're trying to find that right mix of exercise and activity to manage fatigue and improve fatigue, but not to the point of overdoing it. And that can change over time. You have to be smart about it. Practice energy conservation by deliberately planning activities and energy expenditures, so you prevent some depletion. Try and balance rest and activity during times of high fatigue, so that valued activities and goals can be maintained. This can be, the advice I've given people over the years is, they have a big event to go to on a Sunday, a wedding or a party. Well, maybe don't plan to do a lot of other stuff on Saturday, if that's going to be the case. Kind of give yourself that preliminary day or the day before to take it easy, so you have the energy left over for the higher priority event later on. Try and pre-plan activities and look to alternate certain activities with resting, so you don't get a fatigue exacerbated and before those symptoms can occur. Next slide. How can we decrease the fatigue and increase our functional abilities? What tools can we think of? You can hit the button again, Alana. It's going to give a little animation there. Thank you. By increasing function activities, we can lessen and better manage some of the fatigue. So how do you go from, tired Snoopy to happy feet Snoopy? Next slide. There are some techniques we all think about that are kind of commonly out there. They may not be the best options. Coffee and donuts and similar foods, drinks, and supplements might seem like a good idea, but they're really not a long-term effectiveness. We certainly don't recommend what this little kid's doing with the knife and the outlet. That might, give you a charge, but it's probably not the best to combat your fatigue. And certainly, working as a police dog trainer, again, might give you an adrenaline rush, but probably not the best idea for you or the dog. Next slide. Fatigue and function work cyclically. I put these up there because I find them very, very funny. And the things I say in my regular life a lot. But in the past, the usual care for survivors meant rest, take it easy, don't overdo it. More and more studies, as we started to mention, have shown that it's a bit of a myth, and that inactivity just breeds more inactivity and makes us less available to do the things we want to do, and actually doesn't really affect improving fatigue. Next slide. Well, how much should I do? Well, how do I start? That's a question we often get. And the easiest thing for almost everybody is to think about a walking program. It's generally the easiest to get started with for people. There's no cost involved other than a decent pair of walking shoes. You can manage and adjust it to your particular needs. There's lots of ways people go after this. They talk about 10,000 steps a day, which, if you read about it, was really invented by the guy that sold pedometers back in the 60s. There's no benefit that's at 10,000 steps that doesn't occur at 9,000 steps. So, do what you can. Some people measure time. They're going to go walk for 10 minutes every day and maybe try and increase that over time. Some people use the measurements in their neighborhood. I'm going to walk 2 blocks down or 5 houses down and back. Whatever works for you in terms of how you're going to measure your success. It can be simple. It can be complex. If you like gadgets, go ahead and use gadgets. But sometimes it's just, what's around you and what's easiest to let you get started. Next slide. This slide, it's a bit technical, might be a little bit busy, but just I wanted to give a graphical representation of how a certain study showed that people in an exercise group compared to a control group that kind of just did their usual care, they improved their fatigue scores over a variable amount of time. The bottom axis there goes, up to several months at a time. So the exercise groups and the people that undertake exercise programs safely do find that their fatigue levels improve over time, and it can be sustained. Next slide. Again, just another graph showing that in another study, the group that did aerobic exercise and focused on that actually had more improvement than the group that just did resistance exercises. Now, we saw before that the American College of Sports Medicine recommends a bit of both, but the emphasis really, I think, especially in the early stages for people that are trying to, recover their activity and fitness levels, is to really think about that aerobic exercise. Again, that's your walking, if you're capable, if you're comfortable, that can be stationary biking, it can be jogging, those things that kind of keep your heart rate elevated at an exercise level for a consistent period of time. There is something to the fact that we do need to build up strength. A lot of the treatments related to cancer and a lot of the medications people are on, and general inactivity can make you lose muscle mass pretty quickly. So strength training alone is not going to combat fatigue. A good mix of aerobic and some strength training probably is going to give you the longer lasting results. Next slide. And again, just some highlights on how exercise can help survivors. It can help reduce overall pain. It can lessen fatigue. You can improve balance and walking, increase strength, energy, and endurance. It can help manage the swelling from lymphedema. It can provide better bone health, which is important. Improve appetite and eating. It can help maintain a healthy weight. It can encourage people to return to their previous activities, both home and work. It can actually assist with memory and concentration. It can help with some of that brain fog that some people have just by improving your oxygen flow. It can certainly improve people's self-esteem and their mood and their quality of life. If people can manage their fatigue better, they can participate in those things they want to participate, and I think create a better mood for themselves in a lot of cases. Next slide. Before you undertake exercise, and especially if you're somebody that's been through a lot of treatment, and been inactive for a length of time, is talk to your medical team, talk to your doctors. What type of exercises can you do? Are there certain things you should avoid based on your particular history? How hard should you push yourself? Again, that can be different depending on the complex or overlapping of different diagnoses and different conditions some people may have. And what kind of things should you watch out for? What are those things that might occur as a result of exercising that you want to back away from, or report back out to your doctor should they happen? Next. And again, general tips. Try to avoid prolonged inactivity. I know we have a break coming up here in a little while, and I would encourage everyone to get out of their seat if they're sitting down, walk around a little bit, do some stretching, take some deep breaths. We will have been sitting for a while here, so try and be regularly active. Small bouts can really be helpful. Maybe just 10 minutes here. Things like parking at the end of the parking lot when you go to the grocery store, to give yourself a few extra minutes of exercise to walk across that lot. Try and include some strength and resistance training. That can be light weights. It can be things you have around your house, a soda bottle, water bottles, things like that can weigh a couple of pounds and get you started. Consider short, frequent sessions, like I just mentioned. Try and stay hydrated. Try and provide a little bit of time to warm up and cool down as you take some of these activities on. Start slowly. Rome wasn't built in a day. They're still building it, last I checked. So take frequent breaks. You can gradually increase your level of activity. When you can, wear comfortable clothing. Anything that's going to make you feel like you have a little more mobility is going to help encourage a little more mobility. Also, listen to your body. It's okay to slow down, stop. We don't want to cause excessive pain or excessive distress with anything. So you don't, early on, and as you start one of these kind of programs, as you want to undertake this, be good to yourself. You don't have to push yourself to exhaustion or pain. And again, avoid, if you can, prolonged inactivity, other than really good sleep, like Candida talked about. Next, how to set some goals for yourself. We talked about this before, just in terms of walking measurements, but try and clarify the goals for yourself. What are the most important things you want to accomplish? Are those goals reasonable and achievable? Prioritize your goals. Think in terms of short-term and intermediary goals to get some easy wins as you start a progress like this. Try and measure your progress in whatever will suit you best. Like we said, it can be, a journal, it can be a calendar, It can be a digital device, you know, a Garmin, a pedometer, Apple Watch, things like that. And try and identify obstacles. Look at those things objectively that might keep you from achieving your goals, and see if you can address them. You know, if it's a lack of time, you know, try and plan as best you can to create some time for exercise where you can work it in your days. Next. I want to leave you with just a couple of things. Hopefully you can take away some good things from this short talk. Realize that barriers to starting exercise are difficult for everyone, and more so if you've got, you know, a history of cancer, you're surviving, you know, and it's tough. If you're not used to it, or you've not been used to it lately, it's tough to start. Give yourself a chance to get going. Realize that fatigue can have many causes, and it may take a while to get on track. Be sure all your medical issues are addressed or accounted for. Remember that aerobic activity is probably best to get started with, more so than strength training, but include some strength training. Try and modify or pace your activities. Get the proper nutrition and hydration. Keep mindful of that. And I think most of all, try and avoid prolonged inactivity. You know, however you can be active, however you can get yourself moving is going to help you out. And that's my last slide for tonight. Thank you, everybody.
Thank you very much, Ron. So while we're switching slides for Dr. Ram Kumar, so Ron has been one of our core survivorship members since the inception of the survivorship program. So thank you very much. And now I introduce Dr. Ram Kumar. He's an orthopedic oncological surgeon, one and only at Lahey, and section chief of orthopedic oncology at the Lahey Clinic. He maintains professional clinical staff privileges at Boston Children's Hospital, affiliated with Harvard, and Beth Israel, BIDMC, also associated with the Harvard Medical School and part of BILH in orthopedic surgery. His clinical interests are in musculoskeletal oncology, including the treatment of bone and soft tissue malignancies, and his research interests lie in population health as it relates to sarcoma care, cost effectiveness, and health economics, artificial intelligence in survival and outcome prediction, as well as the use of near-infrared fluorescence for surgical navigation and development of novel carriers for targeted drug delivery in the treatment of bony metastatic disease. Deepak, take away.
Thank you very much, Dr. Gunturu. Thank you for the opportunity to speak to this wonderful group here. So as Dr. Gunturu mentioned, I'm an orthopedic surgeon, an orthopedic oncologist, and I run the musculoskeletal oncology program here at the Lahey Clinic. And today I wanted to talk to all of you about bone pain, skeletal metastasis, and what we can do as a service line for you. Just as we get started, I just wanted to kind of provide some introduction to what metastasis to the bone looks like. Bone is usually the third most common site of metastasis from cancers that originate in other organs. Among the various different cancer types, breast, prostate, lung, thyroid, and renal are the most common cancers that spread to bone. But there are also other malignancies that can spread to bone, including myeloma, lymphoma, some of the gastrointestinal malignancies, as well as uterine carcinomas. So of the 5 that we did talk about, the skeleton and the spine specifically are very, very common sites of disease involvement, and they can cause pretty significant pain. They can destroy the osseous structures, and that can lead to pathological fractures. The skeleton is the most important kind of reservoir for calcium in the body, and cancer-related bone destruction can lead to high levels of calcium in the blood, which is called hypercalcemia. When these tumors spread to the spine, they can also cause compression of the spinal cord or the nerve roots that are exiting from the cord and supplying the arms and legs, causing weakness, fatigability, and pain, affecting the extremities as well as the trunk. Unfortunately, metastatic bone disease is very, very common. And with improvement in the systemic treatment options, the chemotherapy, the immunotherapy that are being used to treat a lot of these primary cancers, we are seeing an increased incidence of bone-related complications that arise in this patient population. And so this can cause a significant burden, not only on the patient, but also the healthcare system, with an annual cost so to speak, for all of this care, exceeding more than $12 billion. So we established this service here in the Lahey Clinic approximately 3 years ago. And our goal really in the treatment of metastatic disease to the skeleton is to help maintain patient's function, prevent fracture, prevent bed boundedness or limited mobility, while we keep the patient on their systemic treatment, cancer treatment. And so some of the treatment options that we offer in conjunction with some of our colleagues include radiation, radiofrequency ablation, stabilization, as well as reconstruction of the joints in the extremities. So in order to kind of outline some of the available opportunities for our services, I just have a few cases that I want to go through to give you kind of a live example of some of the patients that we've taken care of and seen through their treatment. So this first patient was a 77-year-old female that came to my office, roughly a year ago now, but she had progressive hoarseness, had trouble speaking, and was having excruciating pain in her shoulder. And so this pain had progressively worsened through the course of time. And by the time she actually walked into my clinic, she was having 10 out of 10 pain, unable to really move the shoulder at all, and was even tearful in the process of explaining the symptoms she was experiencing. So having very, very significant compromise. Since she was right-handed and this was her right shoulder, she was really unable to do much with her right upper extremity, and not even able to lift a cup of coffee with the hand. So we kind of took a look at her shoulder with some x-rays. On the right side here, this is what a normal shoulder should look like. We describe this joint as a golf ball on a tee. And so, the joint is nicely centered and reduced on this image. And if you look at this patient's shoulder, you can see there's this big kind of, gray area up near the shoulder joint. And if you look at the side view, you can see that rather than this part being completely straight, that there's almost like a shark bite that has been taken off of the humerus, the arm bone. So we took her to the operating room. I just want to warn you guys that there are some intraoperative pictures that can be somewhat graphic. So if you're queasy about blood, just turn away for a few seconds. And this is what we saw. So this is her arm, and you can see this whole area here has been a big hole that has formed in her bone. This is the normal bone out here, but big area that has formed a hole in the bone from the cancer, from eating away at the skeleton and leading to compromise. Luckily, we were able to catch this before she broke. So we went ahead and resected and removed all that tumor, filled the area with bone resorbing cement, which was actually designed in part here at the Lahey Clinic. And we reconstructed her shoulder with a nice plate to help hold the bone together and prevent it from breaking. And this is her at her 2-week postoperative visit. You can see she's able to completely move her shoulder, which she was unable to do just a couple weeks before. And so complete restoration of function, within a very, very short time with minimal impact on her treatment. She did so well, in fact, that, a few months, like roughly 3 months later, she actually sent me a message asking if she could go to the driving range and hit some golf balls because her arm was feeling so well. It basically goes to show you how quickly she was able to recover and kind of get back to the normal semblance of life that she had prior to getting diagnosed with cancer. This is another patient, also older female, 76-year-old, who had a bladder cancer and was having significant right knee pain that has been present for multiple months, up to about a year. She was initially seen by another orthopedic surgeon locally, thought that she had arthritis. So she was treated for her arthritis in the knee. She had physical therapy, injections, which all failed. And ultimately, she underwent a total knee replacement. And this is what initially, when she presented, these were the x-rays that were obtained. And she did have some arthritis in that knee. It certainly could have been a cause for her pain. And post-operatively, she had this nice knee replacement done, but still, unfortunately, had pain. And so she was referred to see me. We got x-rays, and similar to that lesion we saw in the humerus, she had another shark bite that was that had kind of affected the tibia, losing the cortical structure and probably the root cause of her pain. So we got an MRI scan just to show how big the tumor was. As we can see, this area is the normal bone. All of this black streaking artifact is from the metal in the knee replacement. And down here, the normal marrow is supposed to be white on these sequences, but we see that it's become dark, much like the muscle around the bone, representative of cancer. And so, well, what did we do? We wanted to prevent her from breaking in this area. So we took her to the OR. We did a very minimally invasive approach initially, kind of removed the tumor, and then inserted these radiofrequency ablation probes to help essentially locally deliver thermal ablation, so heat-based ablation to the tumor to kill off the tumor in the tibia, and then reconstructed that defect by putting in bone cement that's resorbable and a plate to help prevent it from breaking through that weak site. And so she went from being completely wheelchair bound when she initially saw me to being able to ambulate within the course of 2 to 3 weeks. So this is a major impact on her quality of life. She's otherwise a very active woman. Prior to getting diagnosed with her bladder cancer, she went from being, very active, self-sufficient and independent to being completely wheelchair bound and dependent on her husband to do anything. That significantly affected her quality of life, was able to walk after this type of an intervention. Here's another patient. This was a little bit younger gentleman. He was around 57. He was having a lot of hip and thigh pain, and he came to me and he had these x-rays. And this is an example of another cancer that spreads to the bone. And as you can see here, there's been a large area of lucency that has formed in his skeleton from cancer essentially invading the bone and eating away at the normal bone structure. In the process of getting his workup done, within 2 or 3 days after he initially saw me, he was in the shower, and just taking a shower, and all of a sudden he fell to the ground because he had excruciating pain. So he's brought to the emergency department, and you could see that he actually broke through that lesion because it had weakened the bone so much. So he couldn't walk, he was bedbound, and had excruciating pain in his hip. So we took him to the operating room and resected that tumor, took out the whole piece of bone. Here you could see is where the fracture was. This is the area of the bone where we lost the actual bone because of the tumor. And these are the fragments of tumor that had spread from the bone into the soft tissues that were all removed. So we took out this gentleman's hip joint and completely reconstructed it. And here's a nice example of a picture that shows the metal implant that we put in to reconstruct the femur and essentially restore the femur, back to its native alignment. And these are x-rays, again, showing that metal implant that has replaced more than half of his femur, and all the muscles have been reattached to the metal implant, allowing him to have a functional limb again. So you would think, more than half of the femur has been resected. How does this guy walk? Well, here's a picture or a video, actually, a few weeks after surgery. He's using a walker, but essentially back to walking with very minimal limp, and essentially complete restoration of function, and very, very happy with his outcome. So I have one more case to present. I will keep this one relatively short. This is a very young gentleman that presented to us who had groin pain on the left side as well. He was thought to have early arthritis that was developing in that hip. He underwent multiple injections and PT and everything else, but his pain still persisted. So he ultimately ended up getting some advanced scans, including an MRI scan. And basically, these are cross-sectional images of the MRI scan. Front is up here, back is out here, right side is on this side, and left side is on this side. And you can see in the front of the left hip, it looks very different than the right side. There's this mass that had developed right in the front of the hip joint itself. And as you scroll through, you could see that this mass was actually quite large, and was essentially invading the nerve and blood vessel structures that go and supply the rest of his left leg. So he ended up getting multiple opinions from surgeons across both town and across the United States, who had recommended doing a very ablative procedure called a hemipelvectomy, where essentially the whole portion of the pelvis is removed and you're left with essentially no leg, and you're expected to ambulate like this. Given his young age, we thought we could do something a little bit different to help give him some more function. So we really, spared no expense, had no reservations, and we took him in for a big tumor resection. So here's his tumor right here. This is his vessel that has been resected, and we've actually replaced it with a Gore-Tex vascular graft that connects from the aorta up here to the rest of the arteries that supply the lower leg. And here's the tumor removed out of the body. You can see that big mass that we saw in that MRI scan is right here. This is all the bone and soft tissue mass associated with that tumor. And what did we do with the big hole that we now created in his pelvis? Well, we had a custom implant that was 3D printed in metal to reconstruct that portion of pelvis for him. We're lucky, we're one of the very few institutions that have access to essentially an on-site metal 3D printer that can reprint these implants and help essentially close almost any defect of the bone structures. And we can get these implants done very, very quickly so that we can minimize the time it takes to get the reconstruction done. Typically, when most institutions would have to order this implant, it takes about 6 to 8 weeks for it to be made, cast, and brought in. And we can get it here done within a week or so. So very lucky for this patient. Ended up getting this 3D printed pelvis put in and fixed to the remainder of the native bone. And then because he had this problem with the blood vessels, we had to essentially recreate a new leg for him that would be vascularized, that would still receive its blood supply. So we turned up his leg and essentially closed everything up to give him much longer femur and thigh that we then essentially used to create an external prosthesis to allow him to walk. And this is kind of what that looked like. And so he is now a year out from his surgical procedure. He's doing very, very well. He has this external prosthesis with a stump of the leg that has formed from our turnup, and he's able to ambulate. And this is him, several months after his multiple surgeries, and he's actually walking quite well, having just bars for assistance here in PT. But now he's several more months out from this and is actually walking independently without using any assistive devices. So big functional benefit and boon for this gentleman. So in conclusion, a lot of the skeleton is extremely important, as we know, for locomotion and ambulation. We just heard a wonderful talk about being active and moving, and the skeleton is an integral part of allowing us to do that. It is also important in protecting our vital organs. And like I said before, it's an important reservoir for calcium. It happens to be one of the more common sites where cancers can spread to, and it's probably one of the sites where significant pain and disability can occur when cancers do spread to the bone. Now more than ever, we have multiple approaches to treat these tumors. Rather than doing very ablative surgeries where we amputated the legs, like we did in years past, we're able to reconstruct legs using novel methods like 3D printed metal implants, and really help restore a significant function and quality of life for our patients. So our primary goal here of Musculoskeletal Oncology Service is to work together with the medical oncology team in supporting you, the patient, and to try and help maintain your function and independence as you fight your cancer. And so we are really on the cutting edge of clinical practice. We have multiple treatment options that are really only available in a very small number of centers across the country. And we are specializing in minimally invasive limb salvage treatment for a lot of these tumors, thanks to the support that we've received at this institution. So with that, I just want to introduce our team. So this is Kimberly. She's our nurse practitioner. And this is myself. We're generally a team of 2, but we have wonderful support from some of our microsurgeons like Dr. Frenier from plastics and Dr. Claire, who is one of our hand surgeons. And we really are able to kind of deliver all of this at our institution with the support of all of these people. So thank you very much. Please feel free to reach out. If there's any questions, we are happy to see you in clinic and help with any of your ailments.
Thank you very much, Dr. Ramkumar. Many of these procedures and we would not even have dreamed of a few years ago that it is possible, and made with the advances and also with the expertise that you brought to us. This improved quality of life for our patients. And I can speak for my own patients that I sent to, which they have been very happy about their quality of life, and also the interactions, like able to text you, for example, and get your attention right away. So thank you very much.
Thank you.
So we're going to take a break. I hope you can have a bio break or get some stretching while sitting for a long time, and we'll meet again at 6:20. Thank you.
Steak, oh, we're having chicken, but I would challenge you to start thinking about what are we having in terms of vegetables. So reframe it to say, like, oh, for tonight we're going to be having roasted Brussels sprouts and we'll have some pasta and chicken on the side, something like that. We want to be having a very colorful plate. Like I mentioned, we want a lot of different varieties of fruits and vegetables. So one thing that we'll suggest sometimes is thinking about eating the rainbow. Do you have a vegetable from each from each color, or maybe not at every meal, but each day? Are you having leafy greens? Are you having dark green? Are we having dark red? Are we including purple? All these different colors have different micronutrients, so it's important to gather as many into your daily intake as you can. Also, just not being afraid to, when you're going out to eat, or if you're going to a friend's home, to bring a healthy dish with you. Oftentimes, if you share with family or friends that you're trying to eat in a more healthful way and that you're going to bring a healthful dish, they'll get really excited and say, "Oh, I've been trying to do that too. Thank you so much. That's great. I'm happy to see what you brought and share that dish and that meal." Because as we know, as we're getting through this challenging time, being social is so important, and people want to support you. So, if you say, "Oh, I'm eating healthfully," then that can help guide them if they're trying to provide food to you, or also could even lead the menu towards something more healthful as well. So don't be afraid to share that goal if that's something that is of interest for you. When you're choosing foods, like I mentioned, the processed foods are the things we're trying to stay away from, and we're trying to encourage less processed foods. So choosing foods in their most natural form. So when we think about an apple, that would probably be the least processed, versus applesauce versus an apple pie. It's like everything's changing. So if you're choosing apple, we want to choose the whole apple, not just the juice or the sauce. You're going to get more fiber and nutrients from that whole apple. A lot of times people like to journal their intake. And if you have journals of like what you're choosing for your meal plan versus what you ate, that can be a great comparison and a great tool for moving forward. And seeking the help from a registered dietitian or nutrition professional, that can be really helpful in terms of building a healthful meal plan. Next slide, please. Sometimes people are curious about what a healthful eating pattern looks like, maybe looking for books or websites. I would always suggest the Mediterranean diet. It's one of the most well-studied diets that we have about longevity and eating healthfully, and it really aligns with the American Cancer Society's recommendation for minimal processed and processed foods in general, minimal red meats, and a lot more of whole grains, fruits, vegetables, that being the base of your diet, and also a lot of physical activity. Next slide. If you're looking for another strategy, I would suggest the plate method. So in this method, we're looking to fill up half of your plates with fruits and vegetables first, and then the other half being your protein and your starch. So like I said, you're making the vegetable the star of the plate, the star of your meal. Next slide. And then the question comes up with, how are we going to actually do this? How are we going to prepare and make sure that the meals we're eating are healthy and they're what we are aligning with our goals? So before you go to the grocery store, I always suggest taking a home inventory. See what you currently have in your fridge, in your pantry, and then from there you want to plan out your meals. So these are the healthful meals I'm going to have this week based off of what I have. Now I'm going to create my grocery list to fill in the gaps of the things that I need for these meals. Then you want to plan what you're going to prepare each night, stick to that plan, and then set contingency plans too. There might be a situation where, hey, you know what? Turns out I can't cook tonight. Something came up. Well, having a helpful option, having ideas about when these things come up, what am I going to do instead? Like, I know I always have X that I can eat, and I know that that's helpful for me, and that will work. And then wherever you can, just try to avoid unplanned eating, because that's where people get tripped up. If they didn't plan on eating something, someone brings something to the office, oh, that looks great, or someone brings food that they weren't planning on, and then it can be very tempting. So if you can try to avoid unplanned eating, that's really helpful for when you're making a meal plan for yourself. Next slide. It's also interesting to think about habits and what kind of cues us. So as soon as we were talking about movie theaters earlier today, I thought this is a total habit cycle. So you go to the movie theater, there's a cue, you're there, you smell the popcorn. The routine is you buy the popcorn, and then the reward is you're eating that popcorn at the movies, you're having a great time. So this can, maybe when you're going to a movies, you're going to do that. But every day we don't want to be making patterns like this. So if you know that you have a time of day, like, okay, I hit 2:00, I need a cookie, or else I'm not going to get through the rest of my day. Think about like you're going to keep your cue, you're going to keep your reward. Your reward is you're going to feel good. You are feeling more refreshed. You're ready to get back to your day. What you want to do is switch that routine. So instead of grabbing a cookie, maybe it's calling a friend, maybe it's taking a 10-minute break and going for a walk, something like that. You want to keep your cue and reward and change your routine. Next slide. So that's all I have for today, but I'm so thrilled to help refer anybody to a dietitian if you ever need help in the future. Thank you.
Thank you very much, Catherine. So we're going to have more questions, and if you want to put in the chat, we'll address them at the end. Catherine, when you get a chance, there is a question in the Q&A. So thank you very much for all your work during these years. Okay, so our next speaker is Alexis English. She's a physical therapist at the BIDMC Lung Cancer Center at Beth Israel Needham. She obtained her doctorate of physical therapy from Sacred Heart University in Fairfield, Connecticut in 2013, and completed residency at Harris Health System in Houston, Texas. She is a board-certified neurological clinical specialist. She expanded the Lung Cancer Center clinic in 2017 to working with individuals prior, during, and after treatments for cancer. This year, the Cancer Center has expanded care to providing pelvic floor rehabilitation for adults of all genders. Thank you very much, Alexis.
Hi, thank you for having me today. I am very happy to talk to you specifically about physical therapy for the pelvic floor, to kind of piggyback off of the discussion about rehabilitation and activity in general with cancer treatments. And the next slide, please. So the first question that people ask is, what is the pelvic floor? And just in summary, it's a group of muscles that kind of extends from your pubic bone to your tailbone and acts as kind of a hammock for all that sits on top of it. So all of our organs and things like that. And it works in coordination with your diaphragm to help maintain the pressure within your abdominal cavity. And the next slide, please. So there are 5 major functions of the pelvic floor. So as you can see, regardless of the gender of the person, we have the same muscles within our pelvic floor. They just might be shaped slightly differently on the most outer layers, but for all people, the pelvic floor's primary role is to support, again, everything that comes on top of it, and to stabilize our pelvis as we move in various positions, sitting, standing. And of course, we have the sphincteric control, so making sure that we are able to keep our urine, our feces, and our gas in our body when we need to and release them when we need to. There's also sexual functions of the pelvic floor to allow for safe and comfortable sex, as well as maintain erectile tissues in both male and female anatomy patients, and then also to act as a sump pump. So there's a lot of lymphatic tissue within the pelvic floor to make sure that we can promote flow of our lymph system from our legs up into our abdominal cavity to be filtered out. Next slide, please. Pelvic floor dysfunction is extremely common in the general population, mainly for females. Research shows that at least 25%, but upwards of 40% of female body patient or people experience some sort of pelvic floor dysfunction in their life. So that usually can be urinary incontinence, constipation or fecal incontinence, an overactive or painful bladder syndrome, pelvic pain just at rest or with sexual function. Pelvic organ prolapse is also very common. Next slide, please. Pelvic floor dysfunction can come from all sorts of different things. Most people equate it with pregnancy or delivery of babies, but it can also occur from traumatic injury like a fall, repeated straining or repeated heavy lifting, change in hormone levels, and then neuropathy can also affect the pelvic floor. And we'll specifically talk a little bit about how surgery and radiation can also impact your pelvic floor. Next slide, please. So in terms of the pelvic floor and cancer specific treatments, we'll talk mainly about 4 different types of treatments that people that are having their cancer treated may undergo. Now, there are some cancers that it might be a little bit more obvious where people will have pelvic floor dysfunction, like a colorectal cancer or prostate cancer. It might make sense as to why your bowel or bladder function or your sexual function might be different based off of your treatment. But really, anybody that experiences changes to their trunk in terms of like anywhere in their torso can experience pelvic floor dysfunction or worsening of pre-existing pelvic floor symptoms. Surgery can result in pain anywhere. It can also change the organs within your body and create some bowel or bladder dysfunction. It might induce some hormonal changes, so it might put you into menopause or result in some erectile dysfunction. Scar tissue from your surgery can pull on your pelvic floor in different ways. Removal of lymph nodes within the groin can cause a backflow of lymphatic fluid and have lymphatic fluid pool within your abdomen, your hips, or your genitals, or in your legs. And surgery can result in weakness and range of motion changes, especially if that surgery is in your abdominal cavity or around your hips. It can directly impact your pelvic floor as well. Radiation can result in fibrosis of the tissues that are within the radiation field. We specifically treat a large number of people experiencing stenosis of either their vaginal or rectal canal from pelvic radiation, or having pelvic floor dysfunction after radiation in their hip region. Can cause bowel and bladder dysfunction. And then radiation can also result in pain and fatigue, as well as worsen lymphedema or make you more at risk for lymphedema in the genital or abdominal cavity. Next slide, please. So in addition to what was spoken about earlier with chemo fatigue and how exercise can be very helpful in helping to offset some of that, the pelvic floor is muscles just like your quadricep muscles, your hamstring muscles, or your biceps. So fatigue and deconditioning can also affect your pelvic floor and result in bowel or bladder dysfunction. Chemotherapy might cause somebody to have chronic diarrhea, or you might have some medications that make you more prone to constipation. Both things can severely affect your pelvic floor. If you experience neuropathy as a side effect of your chemotherapy, that can change either the sensation in your pelvic floor area, or it can change the function of the muscles. You might experience erectile dysfunction. And then, like we talked about, fatigue or general deconditioning. Then hormone therapy can result in joint pain, especially around the hips, which can affect your pelvic floor. The feet and the pelvic floor work very closely together. So if you're experiencing a lot of joint pain in your toes, sometimes you can have some residual side effects within the muscles of your pelvic floor. Genital urinary syndrome of menopause is kind of an overarching term for people who have entered menopause naturally or induced with hormone therapy. The symptoms that can come from that are like vaginal dryness, irritation, pelvic pain or pressure, difficulty with lubrication, painful intercourse, bleeding with intercourse, change in arousal, painful urination, urinary urgency, incontinence, and things like that. And those are things that people might have had prior to even having any treatment for their cancer, and now they may be getting worse. Pain with sex can also be part of hormone therapy, and then erectile dysfunction can be a result of hormone therapy as well. Next slide, please. Oh, we can go back to the last slide. I'm not sure why there wasn't anything on it. But I can explain. So most people who are referred to pelvic floor physical therapy are like, what are you even going to do? So I just want to briefly touch on if you're experiencing any of the symptoms that we discussed and you would like to have a pelvic floor exam, that's going to look very similar to a physical therapy examination for any other condition. So we're going to look at how your spine and your hips are moving. We're going to look at how you're breathing. We're going to look at your muscle strength. And then depending on what your issue is and what we find in the initial settings, we might do a pelvic floor exam, which can involve both an internal or an external exam of the pelvic floor that was done by your pelvic floor therapist, just with a examination with the finger in either the vaginal canal or the rectum, depending on your issue. This is not something that is necessary in order to treat your issues, but it is often highly recommended to figure out what's going on. But if it's not something you're comfortable with, it is also something that can wait until a later session. So we try to make sure that that's not a barrier for people to start pelvic floor physical therapy if they're nervous about the internal exam. And next slide, please. And then treatment. So I mentioned earlier how your pelvic floor is very intricately coordinated with your diaphragm. So we spend a lot of time working on breathing patterns and coordination of your diaphragm and the muscles that help you breathe. We can also discuss lifestyle modifications, looking at your diet and some different triggers that might make your urinary or bladder symptom or urinary or bowel symptoms worse. We might do some bladder bowel retraining and then general strengthening. A lot of people that undergo radiation don't necessarily need to strengthen their pelvic floor, but they need to learn to relax their pelvic floor. So we teach them how to do that. And then coordinating your movements, and treatment might include internal or external mobilization of the pelvic floor tissues. Next slide, please. So a few points that I want to come across that are kind of general speaking. A lot of times when people have a lot of the symptoms that we discussed, specifically incontinence, they're told to do Kegels or think they're supposed to do Kegels, which are pelvic floor contractions. And for a lot of people that are undergoing treatment for cancer, Kegels will actually make your symptoms worse because it's not the weakness is not the only issue that's going on. So a shortened or a tight pelvic floor needs to be lengthened and relaxed before it needs to be strengthened. So if you've been having some incontinence and you've been doing a bunch of Kegels and it's not getting better, you feel like it's getting worse, it might be that you need the opposite. So stop doing Kegels altogether. If you do just have a pelvic floor that is weak and needs to strengthen, Kegels are wonderful, but that's why if you're having any of the symptoms that we discussed previously, it is helpful to be evaluated by your medical team or pelvic floor physical therapist to see how to best treat those issues that you're having. The next slide, please. And the main issue that most of my patients that I treat for anything related to oncology treatment that we discussed when it comes to pelvic floor is constipation and having trouble evacuating their bowels. And so I wanted to just quickly go over the proper way to go to the bathroom. It is not something that people think about until they're having an issue with it. But we were not designed to sit on toilets, and we were especially not designed to sit on these nice comfort toilets that are nice and high and easy to get up on, which might be nice when you're a little bit deconditioned and it's easier to stand up from a higher seat. But it makes it much, much harder for you to go to the bathroom if you're sitting upright. So when your knees are higher than your hips, like in a modified squat position, nice and supported, it actually relaxes your pelvic floor and makes it a lot easier for everything to pass through your bowels and into the toilet. So if you're going to the bathroom, grab a stool, a couple of books, anything, and get your knees up higher than your hips. Lean forward and rest your elbows on your knees. And then take a nice deep diaphragmatic breath in, so you make your belly nice and big. And then rather than squeezing and kind of pulling your belly in and bearing down, you want to keep your belly nice and big and kind of bear it down, pushing out using your diaphragm and using kind of your upper body rather than squeezing your stomach. So kind of strain to put everything out, and you want to exhale. So we say like belly, big, belly hard, make your belly nice and big and nice and hard, and then exhale and maybe even vocalize a little bit and grunt, and that's going to help open up the sphincters, open up the pelvic floor, and allow your stool to come out a little bit more effectively. And I would say about 80% of the patients that get referred to me with constipation, they start doing this and they're better within 1 or 2 treatments. So yeah, that's it. All right, next slide, please. The other thing that is very common in individuals that get radiation to their pelvis is that we want to reduce or prevent stenosis of their vaginal or rectal canal. So your radiation oncologist will clear you for use of a dilator. The dilators that we have in stock are kind of hard plastic dilators that most people are not very comfortable using. So we highly recommend getting a silicone dilator. And if you are able, having a pelvic floor therapist kind of guide you through how to use and progress your dilators, because it might be something you use for the duration of your life or until you're sure that those canals are as you need them to be. And this could be vaginal dilators or rectal dilators. But yes, definitely try the silicone versus the plastic if the plastic is what you've been given and it's not working for you. Next slide, please. That's it. So if you have any questions about pelvic floor, you can reach out to us at Beth Israel and Needham. And the phone number is 781-453-7500. Thank you.
Thank you very much, Alexis. So this is a lot of good information, and thank you for doing this. And our next speaker is Dr. Sarja Ganatra. Dr. Ganatra serves as the Vice Chair of Research for Department of Medicine and Director of the Cardio-Oncology Program for Lahey Hospital and Medical Center. His primary research interest is outcomes research in cardio-oncology. He serves in the leadership portion on the Research and Scientific Committee of the International Cardio-Oncology Society, American College of Cardiology's Cardio-Oncology Leadership Council, the Global Cancer Consortium Cardio-Oncology Committee, and on the editorial board of Cardio-Oncology Journal too. More importantly, he's been a reliable colleague and friend in many of these programs that we put together, including survivorship, immunotherapy toxicity program, and research. And thank you very much, Sarja.
Thank you so much, Dr. Gunturu, for the opportunity and for very kind introduction. It's been a true honor to working alongside this wonderful team as exhibited this evening. And thank you everyone on the call for joining us. Next slide, please. Next. So as we know, thanks to the wonderful work by our oncology colleagues, and in fact, all other team members who support oncology, the cancer survivorship has grown significantly, as we can see from 1970s to where we are today and what is projected. It's significantly increased for good reason, a lot of work behind it. Next. However, as we can see that most of the cancer survivors are above 50 years of age, and almost 2/3 are actually above 60 years of age, and that is the age where we are also tend to get cardiovascular disease, or at least develop some risk factors for having heart disease. Next. As a result, what we see is a very high proportion of patients with various kinds of cancer. And I'm not going to go into the nitty-gritty detail of every single number here, but as you can see that, a lot of different types of cancer, whether that's breast cancer or testicular cancer in men, or breast cancer in women, or lung cancer in anyone, or even endometrial and uterine cancer, etc. They're all associated with significant high risk of having heart disease and actually suffering bad outcomes as a result of that, to a degree that a lot of cancer survivorship has improved in a way that people can live very long and good quality of life from cancer standpoint, but they succumb to cardiovascular disease and its complications. Next, please. There is kind of a collusion between cancer and cardiovascular disease, and a lot of risk factors which initially we thought they are risk factors for heart disease, some others we thought are risk factors for having cancer, but the reality is that they are shared, and there is much more common between cancer and heart disease than we think, starting from shared risk factors to common biological pathways and impact of cancer therapies, as wonderful as they are in treating cancer and help us manage that. They are not a free ride, and many of them are associated with some side effects on cancer therapy. Next. Next. For next. So as we can see here, patients with breast cancer or kidney or lung and bronchus or lymphoma, ovary, etc. You name the type of cancer, and this is true theme. So without going into the detail of each of them, people with cancer are more likely to have this kind of cardiovascular risk factors, such as blood pressure, cholesterol, diabetes, etc. Now, if the same kind of risk factor is present in patients without cancer, and if they are having X amount of effect on our heart, then patients with cancer tend to have 2X or 3X kind of effect on our heart. In other words, the same degree of high blood pressure or high cholesterol or same degree of diabetes tend to impact patients with cancer and exposure to some sort of cancer therapy more adversely than people without having cancer. Next, please. Next. Thank you. So, the cardiotoxicities are broadly defined into these 5 categories. As International Cardio-Oncology Society, we have tried to define these 5 major categories of cardiotoxicity, and many people in the audience today might have experienced one or the other, having high blood pressure, having low heart pumping function, myocarditis, which we'll touch upon in a bit as well. It's a special side effect from immunotherapy, which are wonderful drugs, but not without, rare but important side effect on the blood vessels or some abnormal heart rhythm. Next, please. While the cancer therapeutics have improved from having those systemic chemotherapy, means getting in intravenously all the time and very toxic, to revolution to more targeted chemotherapies or targeted cancer therapies, I should call them, one would think that the side effects are going down, especially on the heart. However, despite of improvement in cancer therapeutics, the report of side effects have gone significantly up over the period of time. And there are various reasons for that. It's not necessarily because they are more toxic, but also there is more awareness of it and so forth. But it's important to recognize that, because these therapies are more targeted, newer generation, or sometimes even oral pills, they are not without the potential side effects as we used to see with those, IV chemotherapies. Next, please. And this is just an example of how this new generation chemotherapies, these are more of not old chemotherapies. Most of these have been, developed and appeared in practice in last decade or so, some of them even later than that. And they all are associated with significant cardiovascular side effects. And there are various regulatory requirements for cardiac monitoring, even for people on this kind of newer generation targeted cancer therapies. Next, please. So I'm going to touch upon a few, cancers. Breast cancer and heart, there is much more common than what we think. And I think that's a theme for any cancer. They all, kind of gang up on us together, which is unfortunate, but that's what, we are here for, to help you and walk through this journey together. Breast cancer, these are the type of breast cancer therapies, and we have Dr. Thattai in audience and in panel, and she commonly prescribed these drugs and they work wonderfully. However, they are again not without the cardiovascular side effects. So if you are getting one of these therapies, it's possible that either you may have experienced some side effect or you may be considered at risk of having these side effects. So it's important to speak with your oncologist or your primary care physician or your cardiologist to be aware of this and to monitor this. Next, please. Some more numbers that, within 5 years of diagnosis of lymphoma or breast cancer, a person is 3 times more likely to develop heart failure. And that's, significant. Disease burden, we are already suffering with lymphoma or breast cancer, and on top of that, when we develop a serious disorder like heart failure, there are significant symptom burden and consequences of that. Next, please. Switching gears to prostate cancer, again, one of the most common cancers noted in men, and unfortunately associated with various cardiovascular side effects, both from a cancer standpoint itself, but also from various hormonal therapy it requires, as previous speakers and panelists have touched upon, that they have some other organ side effects, and similarly, heart is no exception. It's associated with high blood pressure, abnormal heart rhythm, increased risk of heart attack and stroke, and so forth. So it's very important to be aware of this, and again, kind of managing the cardiac risk factors for reducing, the chance of getting this kind of side effect from hormonal therapy. Next, please. Immune checkpoint inhibitors. Dr. Gunturu and her team prescribe this very frequently. They have become a necessary pillar of many cancers and have truly revolutionized the cancer care and outcome. Many cancers where we used to see horrible outcome within a short period of time, those patients are able to live long and good quality of life as a result of these immunotherapies. However, in rare scenarios, it's not very common, like anthracyclines or Herceptin or hormonal therapy. It is rarer, which is good, but it is still possible to get heart-related side effect from this immunotherapy. One of the dreaded one is what we call myocarditis. That's inflammation of the heart muscle, and when that happens, there are serious risk associated with that of having abnormal heart rhythm, having heart failure, congestive heart failure symptoms, and so forth. So for people on this immune checkpoint inhibitor therapy or immunotherapies, if they are feeling funny, not feeling right, feeling fatigue, etc., do not discount your symptoms. Don't disregard them. It's important to have a heightened awareness around it, and at least we have a wonderful team, again led by Dr. Gunturu and her team, immune response team at Lahey, and they are wonderful in detecting these side effects. But if you are feeling symptoms, it's something to be brought up to your prescribing oncologist. Next, please. And radiation. Many people get radiation therapy, whether that's for breast cancer, lung cancer, and lymphoma, and so forth, brain cancers. However, radiation itself is associated with various heart issues in a long run, and in some ways, actually, way more serious than many other chemotherapies. It takes time. Radiation-induced heart disease takes 10 to 15 years. For low-dose radiation, for high-dose radiation, at least 5 years. So it's not a quick thing, and that's where it gets most tricky, because most people want to forget about their cancer, which we want to as well. But at the same time, the risk of radiation-related heart disease kind of ripens with the time. So as the time passes, it becomes even more important to do usual surveillance as recommended by your team. Next, please. So we kind of reviewed what the problems can be, from cancer therapies, but what do we do? What is our role as cardio-oncology team? Is we use various tools, whether they are imaging tools, and we use them before the cancer therapy, during and post-cancer therapy into long-term survivorship to monitor for many of these side effects and kind of catch them as quickly as possible. Next. Depending on the type of treatment you are on, we have within institution algorithms of how we do various cardiac imaging to make sure that we catch again cardiotoxicity or side effect on the heart very early on. Next, please. This is by International Cardio-Oncology Society, where we have developed this algorithm. But again, the important point here is what we see commonly, especially for Lahey patients, is many have heart disease as a pre-existing condition, and you may need a little different attention than if you fall into younger age group and do not have any cardiovascular risk factors or heart disease. Versus if you do have those things, then we may need to do even more closer surveillance than we would have done otherwise. Next, please. Next. So that was more general. Now, radiation specific, what do we do? So, of course, for people getting radiation therapy to the chest, such as for breast, lung cancer, or lymphoma, and so forth, we recommend various screening for cardiovascular risk factors, but also echocardiogram periodically, and if needed, other imaging techniques. But it gets often overlooked when patients are getting head and neck and brain area radiation or abdominal and pelvic radiation, because blood vessels travel everywhere, and they also tend to get side effect from radiation, and it's important to keep in mind to have appropriate surveillance of these side effects, even if it's not involving your heart. But we need to remember that it still affects your blood vessels, or can affect your blood vessels negatively. Next, please. This is from breast cancer patient population. As the time goes by and as the radiation dose increases, the risk of having heart disease, blockages in the heart artery, goes up. Next, please. However, over the period of time, thanks to improvement in the technology and awareness by our radiation oncology and oncology colleagues, the exposure to the heart from radiation has significantly reduced over the period of time. And these are just two cancers which commonly get radiation therapy. And I'm giving example here that common breast cancer and lymphoma, it used to be significantly high dose, whereas the dose now is as low as possible. I'm sure the future will hold even more promising therapies, but at least the dose has been minimized. And we do thorough planning between cardiology, radiation oncology, and oncology to determine that where we can deliver the maximum effect, but also how do we stay away from other organs such as heart and lung, and do not cause any side effects, or at least reduce the chance of it. Next. Radiation can lead to many of these side effects, blockages in the heart artery, stiffness of the heart muscle, weakening of the heart pumping function, increased heart rate and exercise intolerance, and so forth. Next. And that's why we screen people for cardiac risk factors at the beginning, or when they are finishing up the radiation therapy. Then we see them annually. Once a year, we do the physical exam, ECG. We also get an echocardiogram at baseline, then again every 5 years or so with the stress test to make sure that we follow up on any of the potential side effects and catch them early on. But it's important to remember that, while the radiation related side effects happen in 10 to 15% of people, at least from a breast cancer standpoint, and a little bit higher if it's a left lung or lymphoma, we don't have a crystal ball to tell people that whether you are going to be in 10 to 15% side or you're going to be in 85-90% side who do not have serious side effects. But we do know one thing is people with uncontrolled cardiac risk factors, such as not optimally controlled blood pressure, or high cholesterol, or high blood sugar, or those who continue to have, not the best lifestyle, etc., they tend to be more likely to be in this 10 to 15% people, those who experience the side effect from radiation on their heart. And so it's very important, more important than ever before, to control these risk factors appropriately and aggressively in people with cancer or history of cancer and now in a long-term survivorship. Next, please. Next. This is kind of a general theme that how we, do things in people getting radiation. And again, depending on the type of radiation or the area of the body we have received radiation, we tailor the screening process of how frequently that needs to be done and what needs to be checked. So again, I encourage everyone in the audience and your friends or family members to speak with your radiation oncologist and oncology team or primary care physician if you have ever received any radiation anywhere, not just near the heart, because there can be other blood vessels or other organs can be involved, and you may need to have some screening planning for those. Next, please. So cardio-oncology is not, just one person or a group of people. It's actually, many different services come together to help, from monitoring to preventing to intervening upon these therapies. And it's a multidisciplinary approach, truly. Next. This is just to show, it's a very complicated slide, and I don't mean to, go into the detail, but this is to show that depending on type of cancer you have and type of chemotherapy you are receiving, we decide what kind of imaging or other kind of diagnostic test you may need. And then the treatment is even, more shared decision making between yourself with oncology team and cardiology team, but it needs a complex approach for diagnosis, and many times slightly or quite different approach than what we would do in people without the cancer or exposure to these drugs. Next. I think this has been talked about, and I don't mean to go into the details, but I think the healthy lifestyle is very important, and that's healthy eating and less meat consumption, more plant-based diet, as Catherine emphasized as well. Next. These are the ABCDEs, simple, it's important to be aware and have a blood pressure control, considering aspirin for selective patients, not for everyone. So this is not a general advice. If there is any history of smoking, then it's important to stay away from that. Lowering cholesterol is important, diet and diabetes management, and exercise, and ECG and echocardiography for screening or surveillance. So this ABCD is important, but again, that's not everything is applicable to everyone. So it's important to remember. Next. One thing on, to follow up on Catherine's diet plans. Intermittent fasting, which is growing in fashion, but also with appropriate backup of the scientific literature. This is particularly a small prospective trial in patients with breast cancer. And, when they did intermittent fasting, their risk of having heart disease reduced significantly. And what is intermittent fasting? There are various ways of doing it. But in general, 16 hours of fasting means you are not eating anything, and 8-hour window where you can have, 1 or 2 meals. But again, that's just the schedule of eating. Now, what to eat is a separate story. And next. Catherine has gone into much more detail, but I would still like to emphasize just one thing here, that total meat consumption is directly related with hazard of having heart issues, particularly in cancer patients. So red meat is not necessarily our best friend here in this situation, and it's important to recognize that. Next. This has been talked about, so I'm gonna skip the wellness part. Next. Next. And we are very proud and thankful to all our colleagues to have very busy cardio-oncology program. We see more than 500 patients a year. We do more than 2,000 testing on people with cancer and heart disease, or looking for heart disease, screening for heart disease. We also scientifically, thanks to Dr. Gunturu's leadership and other people in the committee, are able to participate in many of these programs at a societal level and contribute. Next. And not just at Lahey front, but we partner with many other institutes through International Cardio-Oncology Society and Global Cancer Consortium, and work towards helping building cardio-oncology programs throughout the world, particularly in the developing world. Next. And this is usually my last slide, is that, my job is not to put the cart before the horse, but other way around. And we'll be happy to take any questions. Thank you.
Thank you very much, Dr. Ganatra. So it's been an incredible program having you lead cardio-oncology and providing all these resources. Thank you. So our next speaker is our own Amy Fabiani, our advanced nurse practitioner. Many of you know, you have seen her in oncology clinic, and fortunately she has been also part of survivorship program, and where you see most of the time Amy in the clinic. Please, Amy, go.
Thanks, Krishna. So as we're getting closer to the end here, I just wanted to start by saying a few thank yous. First, to all the patients who are present, thanks for taking the time to be here with us. And, certainly thank you for letting this be a part of your care. Alana, our coordinator, who went above and beyond, for this symposium. She goes above and beyond for the survivorship program in general. So thank you, Alana. All the speakers, obviously, for taking time to be here. And then also to Dr. Gunturu, thank you for all the passion you bring to this project. It's been an honor to be able to work with you the past couple of years, and excited to work with Dr. Tatai. Next slide. Okay. So kind of the first question I usually get from people when they're coming in for a survivorship visit is, why have this? What is this for? So, there's a couple of different scenarios where the survivorship visit would come up. One of the more common ways is someone who's kind of through all their formal cancer treatment, whether that be chemotherapy and radiation surgery, whatever it is, you go through a period of time where we're following you very closely. We're seeing you a lot. You have, a lot of access to us. And then all of a sudden you're kind of, free from us, and you're not going to see us for a while. So it's a good opportunity to just kind of check in, see what you might need in order to kind of optimize your health, in between, the longer period of time between when we see you. We also see patients during their treatment, really at any stage of treatment, just to kind of check in and see what we can do to kind of optimize the way you're feeling, optimize your quality of life, or, just take a little bit more time to address side effects. These visits tend to be longer, than you would get in a normal treatment visit, and they focus a lot more on you and how you're feeling. And you often kind of drive the visit in terms of what would be helpful to you, whereas a lot of times in our regular visits they're a lot more treatment focused, and we could just take more time to focus on what you really want to focus on. Next slide. There's two different visit types. The first type of visit is just a one-on-one visit with one of the advanced practitioners. Could be either me or any of the oncology or hematology APs. It's about an hour. So like I said, you do get a lot more time, which is nice. Usually what you do is focus on, the first portion is just kind of going over an oncology treatment summary, where we kind of go over all the treatment you've had to date. We'll then focus on some of the long-term effects people can see specific to the type of treatment you've had. We'll go over what the follow-up schedule looks like for the next 5 years or so. And then also kind of our general recommendations for cancer survivors in general. And then, like I said, we, then kind of let you guide the visit in terms of, what you're experiencing, what we can make better, and come up with a kind of a personalized plan for you. I'm also part of the multidisciplinary survivorship clinic that Dr. Gunturu runs. This is a little bit more in-depth visit. You would meet with not only me, but you'd also meet with Catherine Carithers, our nutritionist, Ron, the physical therapist, and usually Dr. Thibodeau, the oncology psychologist. So you get kind of 4 30-minute back-to-back appointments with each provider. That's just a little bit more in-depth, well-rounded visit. And again, you get that same oncology treatment summary, but leave, with kind of a overall plan. Next slide. And then what can you expect during and after a survivorship visit? As I've already said, we really focus a lot on symptoms, whether it be side effects, things having to do with your cancer, just whatever we can do to kind of make you feel the best you can and, kind of optimize your health going forward. We review the summary, and yeah, that's pretty much it. Next slide. Potential referrals from your survivorship visits. A lot of people are usually surprised by, all the different resources that we have available as we kind of go through your side effects in a little bit more detail. There's often things that don't necessarily come up during your regular visits that can be really helpful to people. So a lot of those providers have been, speaking today, but there's a lot of other things. So we do our best to come up with a plan for really, anything that you're struggling with. Next slide. Thank you. And I just wanted to say, a big thing that comes up, kind of a general theme during my visits, is just kind of this focus on the new normal, the new me. People have been through quite a bit physically, mentally, emotionally when they've gone through cancer treatment, any of it. And it, kind of changes everything about you, but with, a lot of grace and kindness towards yourself, and a good support system, through your care team at home, life, looks really great in the future. So I really love this quote that I found that I just wanted to read. Being a cancer survivor is like being shaken in a kaleidoscope. You grasp for your bearings, desperate to find your balance amidst the chaos. When the dust finally settles, there is a new constellation of colors that are magical and beautiful. Thank you.
Thank you very much, Amy, for all your compassionate care, and also for running this program together with the rest of the team. Thank you.
Thank you.
So we're going to open up for questions. And please feel free to put any of your questions in the chat or Q&A. While we do that, I would like to ask the first question in the chat, which is, are there any foods or vitamins that can help with anemia? I think that goes to Catherine C.
Great. Yeah, thank you for this question. It's a great question. Whenever we're talking about anemia, I would always say we should be talking about whatever the cause of the anemia is. So it'd be a great discussion to have with your oncologist about whether or not they think that your anemia is from chronic illness, or if it's specifically from some sort of process that's happening with your cancer diagnosis and treatment. When we're looking at a solution, we always want to look at the cause and impact that. So if it is a nutritionally related anemia, then nutrition would be the solution. If it's not necessarily nutrition related of the cause, nutrition might not be the best solution. And then there are different types of nutritional anemias as well. So a lot of that could be either B12, folate, or iron. So anemia is a very challenging disease just to give general advice for, but I would say work with your doctor to figure out what the cause of the anemia is, and then the solution will come and follow from that.
Thank you very much, Catherine. Amy, may I ask you to take the second question? How do you define survivorship?
Sure, no problem. So survivorship basically refers to, any patient either who has or is currently being treated for cancer that, is living either with cancer or, in the aftermath of going through treatment. When we think about survivorship and the survivorship phase of treatment, it's kind of, a focus more on quality of life and how to optimize your health rather than, focusing on, active treatment. So that's why a lot of our, visits and interventions, focus on you and your health and, how to make you feel better. Hopefully that answers your question.
Thank you, Amy. So here, if anyone is interested in survivorship appointment, please call this number or talk to your oncologist. Alana will be able to help you to get you an appointment. And on the left here is the scan QR code to reach Dr. Ramkumar for anyone who is interested. So Dr. Thibodeau, can I ask you to take the next question? Can you comment on the fear of dying?
Absolutely. So I would say the fear of dying is probably one of the most common pieces of emotional distress that come with a cancer diagnosis, regardless of the type of cancer, the stage it's diagnosed at. I think cancer in general tends to bring up a lot of our what we call awareness of our own mortality. And so the fear of dying is a common experience for many people with cancer, regardless of where they're at in their treatment, but especially upon initial diagnosis. It's one of the most common things that people talk about in not just individual, but also group therapy.
Thank you, Dr. Thibodeau. Dr. Ganatra, I have a question in regards to the surveillance. Is there for the carotid artery or cardiac, would you consider, I know you put the slide with, especially with the radiation, would you consider doing the ultrasounds or in addition like CT scans or MRIs?
Yeah, thank you for the question, Dr. Gunturu. I think we start with the ultrasound for the most part. So if the radiation was on the chest, then we start with echocardiogram of the heart. Sometimes we do the subclavian, examination, artery. But for the carotid kind of neck blood vessels, we do ultrasound as well for people, those who had radiation in that area.
Thank you. Ron, question for you. So usually we talk about like 150 minutes of exercise, and I can't agree with you more about the best solution for fatigue is exercise. So is there any specific kind of exercises that you would recommend that would be also helpful for cardiac health too, heart health?
Yeah, it's probably the simplest. And the one that people can adapt to the easiest is just walking. We're heading into a pretty nice time of year, right? We're not going to hit super hot weather. We're not going to have any ice, hopefully, anytime soon. So, getting outdoors and walking is probably the easiest to start. And, it's easy to gauge walking and throttle it, faster if you want to, slower if you want to. I think it's probably the best thing to get started. I think Dr. Ganatra would kind of agree that it's one of those great heart healthy activities. It can be taking an extra walk with your dog or going with the neighbor and their dog. It can be by yourself. It can be with a buddy or a family member. I think that's probably the place to start for most people. And if the weather's not suitable to you, walking around your house, doing an extra flight of stairs if it's safe for you. Even simple things like just standing in place, marching in place. You can think back to grade school gym class. Jumping jacks are great. Don't do burpees. Burpees are terrible. Catherine liked that one.
Thank you, Ron. Dr. Oliver, given your work in anxiety and everything, can you comment on how to cope with the anxiety just before the scans come? A lot of people experience anxiety, so do you have any tips?
For managing anxiety generally, or for, you said for scans especially?
Yeah, especially before the scans for our cancer patients.
Yeah, so a huge thing that we talk about with managing worry in particular. So worry itself, we're going to talk about is a prediction about the future that's inherently assuming a negative outcome. Because if I was assuming a positive outcome, that would be more, we would talk about that as optimism or hopefulness. So if I'm worried, I'm generally already assuming something bad. So when we talk about strategies for managing worry, we kind of break it down and we say like worry itself, we can think of it as being three pieces. First thing is catastrophizing. Our brain tends to like to go to the worst case scenario and just kind of stick to that. We tend to overestimate the likelihood that something bad will happen and underestimate the likelihood that something more neutral or manageable or good could happen. And we tend to also underestimate our coping skills, which honestly is one of the biggest pieces. So we kind of imagine this terrible thing's going to happen. And then it's like our imagination just stops right there. And we say, well, that's going to be absolutely horrible. And we don't think about what the next step would be, what our other options would be after that. So when I work with patients around managing anxiety, we kind of talk through, all right, your brain's filled in the worst case scenario. Almost imagine it like a pie chart. Right now, you only have one option. It's whatever this terrible bad thing is going to be. What's best case scenario? And there are some situations where that's still not a good outcome, but it's the better outcome of, how this could play out. So what's best case scenario? What are some more neutral options? Mildly good, mildly bad. The idea here is just trying to remind ourselves that it's not only this one terrible thing that could play out. There's other possibilities here. If we have information to suggest what's most likely, then we also might look at, is there any information that tells us how, what's likely to happen here? In our head, when we only think of that bad outcome, we tend to then assume that is the only outcome. And that might actually be the most unlikely of all of the possibilities here. In other cases, we're assuming we know what's going to happen, and it turns out we have zero evidence to tell us what's going to happen. And it's helpful even just to acknowledge that, which is generally people's least favorite option because we don't know.
But that's still better than, than this assumption of what has to happen. And then the last is, again, what are our coping strategies? Are there, let's imagine that it's not great news. What are the next steps? And some of it's even as simple as reminding ourselves that I have providers on my team. I have other people that are going to help me figure out what those next steps can be. Some of it can be even the simple things of thinking about going into the appointment and like, what do I want to do to prep in the event that it's not good? Do I want someone there with me? Do I want to like clear my schedule for the rest of the day? So in case it's good or bad news, I've got time to process it. Do I want a distraction right afterwards? What's going to help me to just kind of navigate this process? And especially, have I dealt with similar difficult situations before, and what helped me get through that? Were there things that I did that I don't want to do again? And were there other things that were actually quite helpful that I would want to put in place?
Thank you very much. Dr. Tatai or Amy, can I ask next question to you? I'm curious about long-term side effects for long-term port implant. I have to say I am ignorant of any long-term port implant side effects, which goes with regular blood clots or infection, anything. Can you please add on anything you can think of?
I'm assuming that the port is in place. That's what it is.
I'm assuming that, so yeah.
Yeah.
Keep it for a long time, I'm assuming.
Yeah, as long as the port is being flushed, maximum every 3 months, and if it's being used, if it's being flushed and not being used for any medication, it should ideally be taken out. But if it's being used for medications that are a long-term maintenance treatment, some of these medications can cause, like Avastin, bevacizumab, it can cause issues with the port itself being, kind of being exposed or wearing down. Yes, that can happen, but as long as it's being looked at, periodically flushed, especially if you're on treatment, that's going to happen. Generally, other than infection, which we guard against, or blood clots that are associated with it, there should be no other issues. There is a lifespan to these ports. The catheter inside can crack, over time. There can be fibrous scarring formed. But we've seen ports last for years, and generally with no problems, and hopefully touch some wood, no problems. Yeah, so it should be generally all right if it's managed well.
Thank you. So the next question is, my latest blood test showed drop in potassium to below the normal range. What is recommended? I would say it depends on the level of the low potassium. If it is closer to normal, then we usually manage with the diet. And sometimes if it is too low, then we may have to do any other medications. Dr. Tata and Amy, please feel free to chime in.
I don't have a lot else to add, other than, oral supplementation, and, just kind of addressing the cause of it. Sometimes, a medication can be causing it, and, that would kind of drive, our recommendations. But yeah, mostly diet, oral supplementation. If it gets low enough, we would consider some IV treatment. But I think the best thing to do there, it's so specific, would be to talk to, your provider.
Thank you, Amy. Dr. Thibodeau, can I ask next question? What resources are provided and discussed with a social worker during survivorship? Would you be able to answer that?
Sure. So social workers can offer both emotional support and psychoeducation on, various coping strategies. They can help connect patients with an individual therapist, or refer the patient to one of our group therapy programs. They can also connect patients with different community resources. So this could be things like transportation, financial support, helping people with some of the different, paperwork that they need to fill out for various resources and grants. And they can also refer to other community cancer support communities in our area that offer different wellness programming and other support groups.
Thank you, Dr. Thibodeau. I think those are the questions that we have in the chat, and I would like to ask any of our panelists to see if they want to add on anything to their presentation that would be helpful for our survivors and caregivers. Following 3-second rule. Okay, so yeah, so I don't see any further questions, and I would like to thank everyone who came in, attended the symposium. I know it's late in the evening, and for all the panelists and presenters for putting your time together to provide these resources, valuable resources, and also in day-to-day clinical setting too. Thank you very much, and it's been a pleasure being part of this team, and also starting from this program from scratch. I feel that I made good use of what my life threw at me, and I feel fulfilled for doing this to others. And thank you very much. I would like to invite Alana to say a few words, and also Dr. Tatai after Alana, who will be graciously taking over for the survivorship symposium. I mean, not just the symposium, just the whole program, while I go for another opportunity. Alana?
Okay, can you hear me? Okay, awesome. I just want to thank everybody who joined tonight, as well as all of our speakers. Thank you for putting together a presentation on your expertise and how it relates to cancer survivors, and really kind of putting survivorship in the forefront of all of our minds as we see these patients off into the next phase of their life. For any attendees, any patients, or any providers that have more questions about survivorship, you are always welcome to either to give me a call. That is my direct number being shared on the screen right now. That is my direct line. You will get me every time. So if you are interested in an appointment, or you're interested in speaking to one of the providers you heard with today, please do give me a call. I'm always happy to speak with survivorship patients. And I put in the chat, if any patients and attendees could please fill out our feedback form. It just helps us gauge interest for what to present next year and how to make our program better. If you could fill out that form, shouldn't take too long. We'd really appreciate it on our end. The survivorship program only functions if the patients wanted to. And I want to say thank you to Dr. Gunturu. She's been a real mentor to me as I start kind of my first role in the healthcare field. This is my first job out of undergraduate school, and she's really taken me under her wing and instilled a lot of confidence in me, and we will miss you greatly.
Thank you, Alana. You came in fully prepared. I did not have to tell you anything. You took it and ran with the program. Thank you. Dr. Tatai.
Yeah, so I echo the sentiments that Dr. Gunturu and Alana mentioned. Thanks for the presenters and for the attendees who attended the symposium. And I hope that the survivorship issues that were brought up today and discussed helps our attendees to know that they're not alone in what they're experiencing or going through, even long after their treatment is done. And I gained a lot this evening, and I hope everyone who attended the symposium took away something that'll enhance and enrich their recovery and survivorship journey. I want to especially again thank Dr. Gunturu, who founded the program and came up with this concept of the symposium. She's indeed done a superb job putting this together for the sole benefit of our patients and caregivers. And thanks, Alana, for all the background work that went into organizing this and being instrumental in the smooth running of today's evening. So I hope we can do this year after year with new and additional helpful information for our cancer survivors and their caregivers. So thanks everyone and good night.